This is the 12th of the series of www.survivingmold.com discussions. Richie Shoemaker, MD, will discuss laboratory diagnosis of a chronic inflammatory response syndrome, Part 3.
In our first two series of lab discussions, we've talked about HLA, MSH, and VIP, followed by C4A, TGF-beta1, and MMP9. If you get the idea this is a gobbledygook of acronyms and jargon terms, you're right. Hopefully the discussion of hormone events, to follow in just a minute, will be a little easier to swallow without a long learning curve, seeing how these acronyms come into play. But remember that what we have in a CIRS is lack of regulation from neuropeptides such as MSH and VIP. Lack of regulation can include inflammation elements, as we've talked about, but hormonal elements are important as well. We know full well that we find frequently symptoms of unusual headache like migraine and frequent issues of thirst and excessive urination and even static electrical shocks. When you have these symptoms, be thinking of one of the hormone abnormalities in CIRS that involves simultaneously measured levels of antidiuretic hormone, or ADH, or AVP, that holds on to free water in the kidney, and then osmolality. Remember that osmolality is a measure of salt and water in the blood, and that salt and water concentration is regulated normally, very carefully, by the posterior pituitary under control of the hypothalamus. What we find in CIRS patients is that this regulation is lost in over 60% of patients. It is stunning to see how many people will walk around thinking it's normal to need to pass their urine 6 or 8 times during the night and once an hour during the day and not know that antidiuretic hormone is not there holding on to free water. It's an easy blood test. You don't need to go to a fancy lab to measure these, but be sure and measure these levels in the blood. You can measure levels in the urine as far as osmolality goes, but that's not what we're looking at as the marker for lack of regulation. The second element that we need to pay attention to is simultaneous measurement of ACTH released by the anterior pituitary that stimulates release of a variety of glucocorticoids from the adrenal gland. We will measure cortisol as the overall assessment of adrenal gland function, but ACTH must be present in normal amounts to stimulate such release of cortisol. Early on, I was just surprised to find so many people that I saw had very high levels of ACTH. I thought maybe they had an ACTH secreting tumor, but no. What was going on is that their pituitary was reacting to the inflammatory stress of this illness by overproducing ACTH, thereby overproducing cortisol. And when the inflammation that caused all this alarm in the anti-inflammatory mechanisms of the adrenal and pituitary were finally corrected, ACTH and cortisol would go back to normal. So when we measure ACTH, we're really looking to see where are we in terms of kind of the state of alarm of pituitary. We look at cortisol first and ask the question, is ACTH higher or lower compared to what it should be? Similarly, with high ACTH, we find another problem, and that's low ACTH. Here is where we get into some more problems, however, because some physicians are diagnosing adrenal fatigue with their own methods, some of which I approve and some I don't, but nonetheless, if cortisol is low, ACTH should be elevated compared to its normal range. When we see low cortisol and suppression of ACTH, these patients have the worst outcome of all. I get very concerned about physicians using corticosteroid preparations without knowing about MSH and ACTH, the melanocortins, but at the same time if a physician is measuring these glucocorticoids can be used safely. In any event, if you have a rash needing use of a steroid cream or a nasal spray or a lung medication that's inhaled, you can use these corticosteroids without suppressing ACTH. We get in trouble when we use pills or injections of steroids. Disrupting ACTH and cortisol balances and normal biological rhythms makes for a poor prognosis. In part 4, we'll go on to talk about more lab abnormalities.